post. I believe, did it work for you?
Let me share the screen first.
Yeah, go ahead.
Okay. I tried to put it in navigate. Okay. Would this be good?
Perfect. Looks
Can
great.
everybody see my slides?
Yes.
Okay. For whatever reason, whenever I present, there's no case to be discussed. That's interesting. I don't know why.
More time for you.
Somebody's trying to give me more time, I guess. Okay. So I'm going to talk about a methamphetamine use problem. So when I was making the slides, I was scratching my head because I don't know what kind of image I should have put on the first slide, because we have a lot of questions to ask. We have a lot of questions. We have a lot of unknowns in methamphetamine use problem. So this is what I put. I got this image. I tried to answer questions, but actually there's no answers to those questions. I hope from today's how can I navigate? Let me see. Okay. From this half an hour, 40 minutes discussion, then we can talk about some facts, statistics. There are a lot of things we already know. We have talked over and over in the past few years, even in this program, about a meth use problem. So there are a lot of neurobiology changes we have mentioned before, but I just want to give you a little bit of update on what I have read as additional knowledge. Hopefully, we can learn something about it. Then we talk about symptoms and clinical presentation. And finally, I want to give you some updates on interventions, what I could found. Okay. So facts. So this is pretty recent data. 2017 National Survey on Drug Use and Health. 1.6 million people, which is about 0.6% of the population, reported using meth in the past year. And for the past month, it's about 50%. It's about 0.3%. Now, when I read this 1.6 million, so West Virginia State has about 1.8 million people. So we're talking about this is a huge number of people using methamphetamine in the past year, a fairly recent use, okay? And 0.4%, about 964,000 had methamphetamine use disorder, or per DSM-5 is basically a stimulant use disorder amphetamine type. We're talking about specifically methamphetamine in this survey. And that is a lot. Average age of new meth users in 2016 was about 23.3. So we're talking about a young adult. According to 2018 Monitoring the Future survey, which surveys high schoolers, okay, mainly we're talking about 8th, 10th, 12th graders. 0.5% of 8th, 10th, 12th graders had used meth within the past year. This is pretty much same as the whole population. But when I was reading this number, I was thinking about like a normal high school, like Morgantown High or University High. You have like a 1,000. We're talking about you have 1,000 or 2,000 students, because then we have about 5 to 10 people from that school used math within past year. We are talking about this young high school students. So this is a number which is kind of very concerning. And finally, the treatment episode data set. Nationwide treatment admissions for meth misuse dropped from 68 per 100,000 in 2005 to 49 per 100,000 in 2015. So we had an increase of meth use, but in the meantime, we had a drop in the treatment seeking. So that's more concerning. So we're talking about this 49 out of 100,000. If out of this 0.6%, 49 per 100,000 is about 0.049%. That's about, 10% of 1.6 million people actively using in the past year. So we're talking about only 10% people used meth, came to the hospital for help. Actually, if you use 0.4%, those with meth use disorder diagnosis, then it's pretty much about 12.5 to 15% of people came to hospital for help. So that is pretty low percentage. That is really low percentage. So we are here, we have this ECHO program. We focus on MAT and we focus on opioid use disorder population. So this is the data from NIDA in 2021. So overall, national drug overdose death involving stimulants with abuse potential, any stimulant with abuse potential, including methamphetamine, by opioid involvement. We're talking about for whole cycle stimulants, that's about 10,333. About 40% of them used psychostimulants and any opioid. So in other words, people using methamphetamine or other psychostimulants with opioids. So that is, we know that is a very bad combination. So I went online, I went to this Trinetics database. I have only limited access because I only have WVU as one healthcare organization. Okay, so this WVU healthcare organization has multiple hospitals. It includes about 13, 14 hospitals, I believe. So I went to Trinetics. I searched methamphetamine. I used the query. Okay, the query is must have diagnosis. This is ICD diagnosis. This is not really a very, and this database is initiated by pharmaceutical companies, but it has been used extensively in different kinds of clinical studies and many publications from this database. So it's a very legitimate, very good and complete good database for a lot of hospitals. So in our system, in West Virginia University Hospitals, at one healthcare organization, I queried methamphetamine, anytime methamphetamine positive in urine, and any opioid dependence problem or opioid use. There's no opioid use disorder you can search because they use ICD code. But anyways, so this is what I could find. This is what I could find. So total, I retrieved 2,590 patients. This is my circle here. You see that. Now, this is anytime, including actually majority of them happened in the last 3 years. You can limit, you can restrict, actually limit your search to only last 3 years or for last year, last 24 months, whatever. But majority of them actually is last, okay, actually about 50% it's in last 24 months. So here's the thing. Methamphetamine use in urine is about 6,000 patients total in the system. Okay. Well, this number is pretty high as well, because when I say that, you think about 0.6% of the whole population times 1.8 million. And this number is way higher than 0.6%. Okay, now we're talking about anybody used meth. Of course, this is not just the last year, but even if I just use 2,590, if I assume West Virginia University medicine covers the whole state, population. Actually, we don't. And then this number, we're talking about 2,590 patients with both methamphetamine use and opioid use problem. And this is way higher than the number reported by the previous surveys. So we do have a more serious problem. And then I can do a little bit further analysis on this data using this tool, okay, statistical tool embedded in this platform. So out of those patients, the minimum age is 7. It's kind of, I don't know whether it's accurate or not, or whatever, but you can see, if you can see my cursor here, most of the patients are kind of like a little bit over 15. We're talking about 16, 17-ish. Then mean age is 37. So that's kind of, but the standard deviation is 10. So we're talking about, remember the previous slide, I showed like the mean age is 20, people initiate meth use is about 23.3. So we're kind of, that kind of around, around there. Then I went ahead because I was always worried about people getting methamphetamine use disorder diagnosis. Then whether they also have concurrent psychiatric illness or different kind of mental problems. So I went ahead, I kind of, try to figure out whether they have comorbidities of mental disorders. Of course, 100%, all of them had opioid-related disorders. That's in my criteria. But you can see other substance use disorders here. And basically, other psychoactive substance-related disorders, pretty common, 81%. Other stimulant-related disorders, kind of 71%. Cannabis use disorders, almost 50%. Then mood disorders, 75%. Anxiety disorder is about 73%. So a lot of those people, in other words, majority of those patients, they also, in the electronic medical record system, they also carry diagnosis of some kind of anxiety disorder or mood disorder. So then if I expand a little bit more, then I realized actually the mostly diagnosed, diagnosis actually is major depressive disorder, only single episode. And also other anxiety disorders. It's kind of, that's the top of the anxiety disorder list. So that makes me feel like a lot of times we may not give them the accurate diagnosis. Maybe they were they were acutely intoxicated. They came to the hospital. They complain about a lot of mood problems. Or anybody withdrawing from meth, they have severe depression. They're severely depressed, they're suicidal, then we consider that as a major depressive disorder single episode. So, but that's just one of my questions. A lot of questions we can answer from this data. But finally, which is kind of very relevant to us, is how many of these people are on Suboxone treatment or buprenorphine treatment? So this is at any time. You see, I did not limit to last 24 months or 12 months. I can actually I can specify the exact time period. 58%, about 1,500 patients are or were on buprenorphine. Then I also try to figure out other medications they used, sedatives, hypnotics. The lorazepam is the number one. That for antipsychotics, Haldol is the number one. What does that mean? That means methamphetamine use is a pretty bad disorder that can cause acute psychotic problem, including aggression, agitational behavior, and they may need B52. For those who are not familiar with B52, we're talking about Haldol, Ativan, Benadryl, this kind of combination for severe agitation, behavioral disturbance, all these kind of problems. So this is what I could get from the Trinetics. So what does that mean? Basically, I think my conclusion is yes, in this state, we have a lot of problems with concurrent methamphetamine and opioid use, and we don't have enough patients on buprenorphine treatment. And we still don't know those people whether they get better or worse when they're on buprenorphine in terms of their methamphetamine use. But what we know is those patients, if they came to the hospital, they tend to be diagnosed with mood disorder or anxiety disorder, and they may receive combination of antipsychotics and benzo for agitational episode control. So this is what we see every day. This is what I do every day, actually. And I'm running a psychiatric intensive care unit, and I have 11 beds. Every day, day-to-day basis, I have about 2 to 3 patients out of 11 came to the hospital because of some drug-induced psychotic behavior. And most of them are methamphetamine nowadays. So this is NIDA. This is from NIDA, methamphetamine versus cocaine. And we know both of them are stimulant, and cocaine could be used as a local anesthetic medicine. And methamphetamine mainly is man-made. Cocaine is plant-derived. That's why cocaine is more expensive, and methamphetamine is more accessible, and also it is cheaper. And the big difference is methamphetamine. We know that methamphetamine half-life is much longer. It's 12 times of cocaine, and basically people can have long-lasting effect from methamphetamine, and for many days, even with mild use. So neurobiologically, the difference between methamphetamine and cocaine is methamphetamine increases the release and blocks the dopamine reuptake. So it blocks the reuptake, blocks the recycling, and also increases the release. For cocaine, it only blocks the reuptake. So we're talking about methamphetamine effect on the magnitude of dopamine surge is twofold, is more. And finally, there's limited medical use for ADHD, narcolepsy, and weight loss. Now here I have to say this, which is very important. Methamphetamine as a medication from pharmaceutical companies, the dosage is 5 milligram. If you check any online source or even Epic system, methamphetamine, if you any database. So methamphetamine, we're talking about for ADHD as a medicine, prescription medicine, and that's methamphetamine, mainly hydrochloride. And mainly it's only 5 milligram. But have you ever heard anybody abusing milligram of methamphetamine? No. But when patients reported to me about their use, they use half gram, a gram, or 2 grams. That's very. We're talking about the the difference is not comparable at all. So yes, there's a limited use for ADHD, narcolepsy, and weight loss, and the limited medical use as a local anesthetic medicine in some surgical procedures for cocaine as well. We know that. So this slide, actually, this image has been used in many places. So the greenish, yellowish, and the red area, highlight area, basically a striatum, which is part of the basal ganglia. This is the striatum. Dorsal striatum is mainly related to body movement and habitual formation, habit formation. Talking about, and the ventral part of the striatum mainly is nucleus accumbens. We know that that's heavily involved in rewarding circuitry. So in summary, we're talking about these highlighted areas in the brain, subcortical area region, is very much related to our memory, to our learning, acquiring information, retaining information, and body movement. And the first image, the first one is from a healthy person. You can see those red, we're talking about these areas in red, highlighted in red and green, mainly is kind of activities of dopamine, mainly is the dopamine activities. So then you can see after 1 month of abstinence, actually, that's still affected by methamphetamine. They're still not really that active, but after 14 months of abstinence, and we can see the meth user's brain and striatum area, the activity of the dopamine, talking about dopamine level and activity is kind of approaching the normal healthy brain. So that is kind of encouraging thing. So that means, yes, with a long-term abstinence, the brain, talking about the brain, even like dopamine activity can approach the normal level control, normal control person. So that's good thing. That means treatment can help, can regain. We're talking about executive, mainly we're talking about memory, learning, cognitive function, all this kind of things can improve. And this is a very fancy slide. It's kind of a lot of fancy terms and a different kind of, molecular terms, but we don't need to know that. The most important thing what I'm trying to explain here is, so this is the neuron. This is the presynaptic terminal and the postsynaptic terminal. This is how our neurons communicate with each other through the synapse. So the dopamine is released from the presynaptic terminal, and the dopamine is going to bind the receptors on the postsynaptic postsynapse, then trigger a downstream pathway change. Okay, so what happens in methamphetamine use? So the methamphetamine can increase the dopamine release and block the dopamine reuptake by working on the two transporters on the presynaptic neuron, and basically increase the dopamine, causes dopamine surge, increase the dopamine concentration in the synapse, okay, in this cleft. But what it can also do is not only trigger a lot of change in the postsynaptic neuron. Actually, what happens is it can also increase the glutamate activity, okay, of the neuron. Postsynaptic neuron can cause ER stress, endoplasmic reticulum. And if you remember that from the high school biology or undergraduate biology class, basically it's related to the transcription, translation, all this kind of gene level changes, right? And then we have all this reactive oxygen species talking about peroxide, superoxide, and free radicals, all these kind of things. But what happens is basically the dopamine surge and the methamphetamine itself can affect the neuron stress level, can cause the neuron damage or death. This is important. So in other words, what methamphetamine does to our neurons is just causing neuron damage or neuron death. And another thing is the microglia cells. Microglia cells are kind of immune cells or like security guards of our central nervous system, neurons. So what happens is basically it shapes the neuron, it helps the neuron genesis, it cleans out the bad neurons, and can basically, it does that kind of job. So what happens with methamphetamine is methamphetamine can trigger a lot of changes on microglia cells and trigger a huge increase of interleukin-6, which is kind of very important in kind of inflammatory process. Mainly we're talking about interleukin-6 is very important. It's kind of, it can cause cell death. It is very much related to actually a lot of disease, including, we're talking about including the cancer as well. So those kind of things. So we're talking about overall, the excessive methamphetamine use can cause neuron death or damage. Then this is a summary. I tried my best to review this article and give the summary. I think this is the best sentence to describe how methamphetamine affects our neuron cells. So the process of neuronal impairment by meth is closely related to oxidative stress, transcription factor activation, DNA damage, excitatory toxicity, and various apoptosis pathways. Apoptosis basically program the cell death, right? And thus we reach the conclusion here that meth-induced neuronal damage attributed to the neurotoxic and the neuroinflammatory effect of the drug. So in other words, methamphetamine is neurotoxic and can cause neuroinflammatory changes of our neurons, can cause brain cells change, can cause memory problem, can cause problems with our executive functioning, it can cause problems with our learning, can cause problems even with our body movement. So that's the neurobiology of methamphetamine. Not only just we're talking about all those things around this rewarding circuitry, the methamphetamine itself is a very toxic chemical to our neuron cells. So I guess we all know the symptoms of methamphetamine and meth-induced symptoms, problems, right? We're talking about acute use and long-term use, the chronic use. But in summary, actually methamphetamine induced problem is complex, and then those can mimic a lot of different kind of psychiatric conditions. That's why a lot of patients got a diagnosis of mood disorder, anxiety disorder, psychotic disorder, but once they stop using, once they become abstinent for a while, and they're fine. They probably don't have any psychiatric illness. So there are mainly three different groups of symptoms for those meth use people. Okay, so the first one is positive psychotic symptoms. Basically, we're talking about positive psychosis, right? Hallucinations, delusions, disorganized thoughts, bizarre behavior, disorganized speech. And then we have affective symptoms, mainly depression, suicidality, guilt, feeling guilty and hostility and all this kind of self-neglect, all those kind of problems. Then finally, psychomotor symptoms. Remember the striatum change. Actually, dorsal striatum is related to our body movement. So that we're talking about excitement, distractibility, motor hyperactivity, all those kind of symptoms. So mainly psychotic symptoms, mood symptoms, and psychomotor change. This is I got from the same article by Paulus. So the clinical presentation, the transition from casual to compulsive use of methamphetamine can be very quick, can be rapid. So one article said it's about 50 days from onset of use to the first drug craving, and 60 days to regular use and 85 days to compulsive use. So in other words, you use methamphetamine, most likely after 1.5 months, you start to crave for methamphetamine. Then very soon, around 2 month time, you will start regular use. Then in less than 3 months, when the whole control is lost, basically it will be compulsive use. About 36.5% of individuals report psychotic symptoms. If we look backwards, because the problem is like people, even after stopping using methamphetamine, and the psychotic symptoms can reappear after even a certain period of abstinence. So that is a problem. And it could last long. Sometimes like after 6-12 months, we still see that kind of psychotic symptoms. I had a couple of patients like that. So if we consider lifetime symptoms, then the percentage increased to almost 43%. Now, comorbidity of other psychiatric disorders, we're talking about mood disorders, it's about 16%, psychotic disorders about 13%, and anxiety disorders about 7%. So this is a high percentage of comorbidity of other psychiatric illness. So the trajectory of the methamphetamine use. For younger individuals, usually they use it for recreational purpose or as a performance enhancement. A lot of other people could self-medicate to cope with stressful life events. You have heard that from your patients many, many times, I believe. Now, women are more likely than men to report using for weight-related issues. And this is particularly high for among adolescents, young adults. Then there's emerging evidence of using methamphetamine as an opioid substitute to obtain a synergistic high or to balance the effects of opioids. So we're talking about mainly to counteract the effect of, especially the downing effect of the opioids. That's pretty common as well. Then the course of methamphetamine use disorder is often characterized by repeated periods of intense use with intermittent periods of sobriety and relapse. It's very interesting because a lot of people will tell you, actually in one article I reviewed, and actually it's, many people are not really daily users of methamphetamine for whatever reason, because I guess it's very hard for you to use meth every day. It's such a bad drug. It's such a toxic drug. For most people, majority of people use it like, intermittently. Then those who do not undergo treatment show 5-year remission rates of up to 30%. That's very interesting number to me. We're talking about 1/3 of meth users, they never come to hospital, and then after 5 years, they attain the remission. But we don't see this kind of patients because they never come to hospital for help, right? Those who do undergo treatment, 61% relapse within the first 12 months, and another 14% relapse during years 2 to 5. So that means overall, methamphetamine use disorder is a chronic, relapsing, and a possibly degenerative condition, which is consistent with the profound molecular change induced by methamphetamine use, which I summarized in the previous slides. So it is a very bad disease. If you say substance use disorder is a bad disease, I think the methamphetamine use disorder is the worst. That's what I can summarize. So interventions. Do we have any? I don't know. I went to UpToDate, I went to different textbooks, I tried to figure out what are recommended treatment. But the best treatment you can get is from clinicaltrials.gov, right? So the best treatment, the evidence-based treatment, including therapy or we talk about neuromodulation or medications, it should be from clinical trials. So I went to clinicaltrials.gov. I searched by methamphetamine. I searched by methamphetamine and buprenorphine. I couldn't find anything, zero. But I searched methamphetamine. I retrieved 182 studies. That's pretty good. So 75% about, we're talking about 141 plus 3 in Canada, in North America. So this is the current data. I summarized a little bit, okay. So this is the current data from on methamphetamine from clinicaltrials.gov. So out of 102 projects have been completed. 9 of them were terminated. Some with a kind of interesting reason. The 32 are still recruiting. The study type, we're talking about interventional. So giving some kind of intervention, either medication, neuromodulation, that's most of them. And also we're talking about medication and behavioral treatment. So those 3 pretty much cover every intervention, almost all interventions I could find. So 174 with intervention. Only 49 so far with results. But if you go a little bit further to PubMed search, there were less 20 articles, publications can be found from clinical trials on methamphetamine use disorder. So I went a little bit further. Because the good thing about clinicaltrials.gov, you can narrow down your search. So I tried to narrow down, try to find out what kind of drug interventions were used by people. Well, you see here, every medicine, right? All different kind of categories, including muscle relaxants, including micronutrients. However, I have to explain because it surprised me that I went back to all these 182 trials. Actually, anytime they mention a medicine, even the medicine was used in the trial, could be used in the trial. For example, diazepam, Valium. Valium was never really used as a medicine, trial medicine to help with methamphetamine to see whether it's effective in methamphetamine treatment. But Valium was cited here, and in the previous category, actually it was used in one study as a medicine that you can use if patient suffers severe withdrawal that cannot be helped with other medications. So in other words, this list is not really very accurate because you can see that actually we're talking about even this list is kind of overlapping all the time. But anyways, what I'm trying to show you is that basically antidepressive agents 26, antipsychotic agents 14, and buprenorphine was 12, and the psychotropic drugs is kind of 36. My psychotropic drugs should include everything. But overall, we can see most of the medications are kind of psychotropic medications, and the majority of them are antipsychotics or antidepressants. So that's that's what I got. So this is my summary, including a brief review of a couple of other articles. So there's no sufficient evidence that pharmacological interventions by themselves are useful. So far, no, none of them. Results from studies using behavioral interventions are more encouraging. Contingency management plus community reinforcement increase the number of abstinence for patients. So this is very important, abstinence days. So brief cognitive behavioral therapy resulted in significant reductions in the frequency of meth use, the disorder severity, the number of days of use at weeks 4 and 12. So in other words, yes, behavioral treatment could be helpful. And behavioral activation, mainly we're talking about behavioral activation here. In this specific article, they talked about to maximize activities that are not drug related, but are positively valued by the individual. I know Dr. Herschel has been emphasized that many, many times. So was associated with abstinence of alcohol, tobacco, opioid, and methamphetamine use itself. So a beneficial association of exercise, mainly aerobic exercise, with reducing kind of this association with exercise, positive exercises, with reducing methamphetamine problems, so symptoms. And finally, there are a lot of new articles on computer-delivered interventions and app-based approaches, but they're not conclusive at all. But there are problems of all these studies. The big problem with all these studies, they all had high dropout rates. Some of them, we're talking about 70%. Very quick, in a short period of time. People don't stay in treatment long, they stay in trial long. And finally, there was very little understanding of the mechanism, how those things work. Exercise, we talk about, and behavior activation, and the behavior cognitive therapy, and we know, but the mechanism, still, there are a lot of questions to be answered. So that's the thing. So finally, I have a few slides to summarize a couple of very interesting things. Two Iranian studies. So the first one, from the same group. So the first one is about randomized clinical trial on the effects of bupropion and buprenorphine on the reduction of methamphetamine cravings. So if we cannot help with long-term methamphetamine use problem, then how about methamphetamine cravings? I tried to summarize the whole article in one slide. So I think, so the left side, you see the design. Basically, they had two arms, total 65 patients. Still use the DSM-4 diagnosis. Then one arm, 35 patients received buprenorphine, 8 milligram a day. The second arm, they received buprenorphine at 300 milligram a day. The exclusion criteria, I paid more attention. I said, well, if you use buprenorphine to treat somebody for cravings, for meth cravings, you want to make sure the person is not using opioids, right? Actually, they did a good job. They excluded people with opioid dependence problem. So which is good. They also excluded all these kind of people with a cognitive problem, unstable psychiatric conditions or medical conditions. What it really lacks for me, from my standpoint, when I read this, because there's no standard care for methamphetamine use, then they should include a placebo arm. But there was no placebo arm, right? Because because there's no standard care. You compare with buprenorphine. That doesn't mean, because we don't even know buprenorphine works or not. So what's the use of that? But anyways, so they observed the patients for 2 weeks. Then they mainly measured the methamphetamine craving score, and they did a good interview by psychiatrists, and they also used a negative urine drug test. So the conclusion is that both medications were effective in the reduction of methamphetamine cravings. Administration of 8 milligrams of buprenorphine a day can be recommended for the treatment of methamphetamine withdrawal cravings. We should note that it is to be expected that cravings decreases over time without any medication. So who knows? Same group published another article in 2017. The Trials is a pretty good article, by the way. Okay, it's a pretty good journal. It's a journal with an impact factor around 2, so it's pretty okay in substance use overall. I mean in clinical trials. But anyways, so comparing, the same group did the same. They also compared the effect of buprenorphine and methadone. They weren't trying to. They wanted to find out whether methadone and buprenorphine, whether they could help with meth cravings. So it was still the same, almost a same design. They still did not have a placebo arm. 40 patients, 50-50. So 20 patients received buprenorphine and 20 received the methadone, 40 milligram a day. And the conclusions both, they observed, they followed patients for 17 days. They used the same craving score and interview, and both were effective in decreasing methamphetamine cravings during methamphetamine withdrawal. So reduction of cravings in the buprenorphine group was significantly more than the methadone group. So what they're trying to say, well, buprenorphine is safer, buprenorphine is better overall than the methadone group. But again, still, we don't have a placebo to compare with. Another thing is, the big problem with these two studies is they claim it was double-blinded, randomized clinical trial, but actually cannot double blind because one buprenorphine is sublingual. Then the methadone and bupropion, basically it's oral. So it's basically that you cannot really double blind, but that's what they claimed in the article. So, okay. Finally, the association between methamphetamine use and retention among patients with opioid use disorders treated with buprenorphine. So this is our population. So our population is, we have a lot of patients with opioid use disorder. We maintain them on buprenorphine, Suboxone films, actually, or tablets, buprenorphine-related products. So this is a study on 799 patients in Washington State. They followed up the patients. They found the majority of patients, actually, in the sample patients initiating buprenorphine, methamphetamine use was common. How common? 30%. Per their study, 30%, 1 out of 3 patients were using methamphetamine. So that's pretty high. I mean, we probably don't have that high, I don't know. So per Trinetics, at least I don't think we have that high. But anyways, so for our population, I don't know. But anyways, so in this study, and the 30%, and the majority of them, about 60%, 66%, I don't remember the exact number, but a majority of them did not use methamphetamine on daily basis. We're talking about this, just that they use it regularly, but not really every day. So methamphetamine use was associated with a higher risk for buprenorphine non-retention. This is for sure for people who use methamphetamine, comparing with people who do not use methamphetamine, and the retention rate is definitely lower. So now that is very consistent with what we are seeing here. So the last slide. So summary from meta-analysis. This is from a meta-analysis from 43 studies, total collectively 4,065 patients. The most consistent positive findings have been demonstrated with stimulant, talking about treatment of methamphetamine use disorder, stimulant agonist, talking about dex or dextromethamphetamine or dextrin, and methylphenidate, and naltrexone and topiramate. So here's the thing: 3 medications are kind of most consistent positive findings. So think about our clinic, think about your patients. Now we do not allow patients on dextromethamphetamine. We do not allow patients on methylphenidate. That's one is out. Second, the patient is on buprenorphine, then the naltrexone cannot be used. That's a mu antagonist. That is out. So what we have from the studies, as something from the literature review, topiramate, Topamax, 200 milligram a day, it has showed some weak evidence on helping people with abstinence time and also retention. Okay, that's in treatment. Then finally, less consistent benefits have been shown with the antidepressant bupropion and the mirtazapine. Now, I use Remeron a lot. Dr. Husted probably also does that. So we use Remeron on patients on DDU or on my unit when they mirtazapine, which is antidepressant, on patients with methamphetamine use. My finding is, at least from my follow up with those patients, I think some patients really like it. The studies, actually there's several, I think 3 or 4 studies on mirtazapine use on meth use people. So mainly they use, first they use high dose, 30 milligram a day. The second is it's a special unique populations, mainly homosexual men population. The study, the size is not really very small, but it's not a really, it does not probably, that cannot be extrapolated to general population. So it's very hard for you to generalize to everybody. But at least I think mirtazapine is a medicine worth consideration in our MAT clinic. So this is a medicine you can start like a low dose, 7.5 probably, and then bump it to 30 milligram. And some patients really like it, and they report doing well. So some other medications I've never used it. Riluzole, I never used it, and Paxifont, I don't even know what it is. So basically, those medications they were studied, but not really strong evidence. So antidepressants, finally, in general, antidepressant medications, even if they have been studied extensively in this population, including SSRIs, SNRIs, TCAs, have not been effective in reducing methamphetamine or amphetamine use. So that is the conclusion. So we don't know. It may be used for people with comorbidities, talking about if they really have mood disorder, depression, anxiety issues, that could help. But for methamphetamine use itself, it does not have real evidence-based benefit. So those are my references. I think I have a little bit of time that we can have a discussion or any questions.
Thank you so much, Dr. Zhang. That was very informative, and you have great references and resources that I will be making sure I send out to everybody as well. In the chat, there was some discussion about treating meth use through contingency management and using matrix CBT model.
Yes. I
didn't know if they wanted to further discuss that or have any further comments on that.
Probably Laura can help me make more comment on that. I think like I said, contingency management and the CBT definitely, have evidence and more encouraging evidence as well. Yeah, and we know that for now, we know that the real thing that can work for this population is behavioral treatment. Yeah.
Yeah, I actually was in a lecture with one of the folks from California who had helped develop contingency management back in the 90s, and he basically compared the efficacy of contingency management to treat stimulant use disorder as similar or on par with antibiotics. And so it really has very powerful outcomes. It's just not had the uptake among providers that we would like to see, in part because it actually costs a little bit of extra money to do, because you have to provide incentives, which are often monetary, and it's a very tight sort of delivery system. So anybody who remembers their behaviorism, you have to reward the behavior very quickly. And so it needs to be actually a very simple design. We are experimenting with implementing this in some of our clinics, in our co-clinics here. And I think we're going to share those results with folks as we get them. I think it's only been going about 5 months, so we're looking for about 6 months of results. But contingency management is the evidence-based treatment for the treatment of stimulant use disorders.
Thank you so much for adding that in there in your comments. Dr. Husted's including something in the chat. It's a study on, go ahead, Dr. Husted, I'll make sure I include that too.
You're good. I think you probably didn't talk about it much because we're focused more on Suboxone here, but there was the big study about Vivitrol plus Wellbutrin for stimulant use. So that has some evidence too. If people haven't heard about it, it came out late, kind of earlier in the year, kind of late last year. But that's the link to it if people are interested. That's kind of a sidebar. So if you have Vivitrol patients, combining that with Wellbutrin, it's kind of hard to replicate in practice because it was Vivitrol every 3 weeks plus 450 XL of Wellbutrin, but that lowered relapse rates a little bit too. So something, certainly if you have somebody on Vivitrol, you could consider adding Wellbutrin to it, which is already kind of a known commodity with Contrave, which is a diet medicine, but this is a little different for this population.
Thank you so much, Dr. Husted. I'll make sure to include that in the recap for everybody to have access to, and what Mark included in the chat as well. Are there any further comments or questions? We have about 5 minutes, and we are going to be...
I have a question.
Go ahead, Dr.
I was interested in the high numbers of psychiatric pathology related to methamphetamine use. So depression and anxiety, and wondering how much of that is withdrawal from methamphetamine and how much withdrawal drives continued use of methamphetamine. And so if we got better at treating withdrawal, I wonder what impact that would have on the use.
It's very, yes, to be honest, it's very hard to tell. It's a really, that's why I always questioning, I always question whether we ever made a good diagnosis of psychiatric comorbidity while patient is kind of, we're talking about still very close or in active use, or just did not have enough abstinence time. So it's very, I guess the guideline tells us we can never really make a good diagnosis until they're really sober for a good while. But meth itself, like I said, my observation, people on my unit, when they used methamphetamine, they got intoxicated, they got aggressive, they got into trouble. That's why they sent to a hospital always by the cops or by somebody else who noticed the problem. Then they come to the unit, they got so aggressive, they require a lot of psychotropic medications or even benzo and to help them calm down. Then after 3-5 days, they sober up, they wake up and they leave. So basically they don't stay in treatment. So once but then of course they're severely depressed, they have to use it. They have to use it to feel better. So that's for, if you ask me, a psychiatric ICU methamphetamine use, they come, then they just leave after 3-5 days and continue to use. So for those people who really also have opioid use disorder problem, then I think Suboxone is a really big hope, because I have several cases. Actually, I keep them on Suboxone, but in the meantime, they're compliant with treatment. Then they tend to be much better. Then they sometimes they could, we were able to discontinue the psychotropic medications because they really don't need it anymore once they're sober, for a while. Then Suboxone is the main thing that can keep them in treatment, and of course they have to take Suboxone. They have no choice. So that's the thing. So yeah, Dr. Hughes, I agree. And this is Dr. Hirschler. I really don't know. It's very hard to say. I mean, but by the way, methamphetamine itself is such a strong stimulant. It can really cause a lot of mood changes itself. Yeah.
Another interesting thing, when I treated cocaine use disorder in Baltimore, a lot of patients would say they got that first intoxication, that first high with the use of crack cocaine, and then they would be chasing that feeling over and over again, trying to recreate the same kind of intense euphoria that they experienced when they first used it. And I don't hear that with methamphetamine. It's interesting. I wonder if it's the way they're using it or why it's not an intense euphoria that they're chasing. What do you think about that? Do you hear that, or what do the patients say?
I think that people told me the meth use basically, as I don't know much about cocaine use problem because we don't see it very often. But I think that when they use it, they really chase the high. When they use it, they chase the high. Before they use it, chase the high. But right after use it, they have to fight the low. So chase the high, fight the low. That's basically what they do all the time, every day. So that's why I think the difference between methamphetamine use and this is my I never really got scientific evidence behind that, but I think methamphetamine is positive reinforcement is very high. That's why it's so high. The magnitude of dopamine surge is too high. Then they're just we're talking about that kind of confidence, that kind of sexual change, energy level change, or no need for sleep. Those kind of things. It's too positive. Then they have to chase it. But for opioid use, they don't use it. They're miserable. They cannot have a normal day without using. So that's why the Suboxone is such a wonderful medicine, because they can keep them feel normal, so that they can engage in treatment. Then they can do other things. But methamphetamine, you just have nothing to compare with it. So nothing can make them that high.
I like to jump in here. One thing I do know about is, on the methamphetamine, it is definitely a longer, when you use it, it's a longer stretch out, where cocaine is that short time frame. I hit it, I got high, I'm going to chase it again by doing it repeatedly. But with methamphetamine, you don't have to do it repeatedly to get the same high. It is an extension. You can smoke it or however you take it, you get that high, and then you're actually high for hours. And then if you do a little bit more, you continue that hours to days. So with the methamphetamine, it's a lot worse than cocaine, because that cocaine is the short-term high, where methamphetamine is a long-term high.
And it's also so cheap. It's just that people told me like $5, or even like people like to share with other people because it's so cheap.
Yeah, you can get a lot more meth than you can for coke for the price. And then the problem is that you also got the shake and bakes, those who are making it just right next door, and you don't know what you're getting. And that's what's scary. because I've seen people make it in different ways. You know, you're using battery acid, you're using matchbook strikers, you're using camping fuel. It's amazing what people have put in their methamphetamine. It's just to make it better or different than somebody else's.
If anybody wants to watch people make meth, there's 2 shows on TV. First one is Drugs Inc. There's an episode, I think it's in Kentucky, somewhere Appalachia, not us for once, where there's a guy literally in the woods with a soda bottle making it. And then there's Hamilton's Pharmacopoeia. It's a relatively newer one, but Hamilton's Pharmacopoeia, I'm about 80% through it myself, actually, so not done yet. But there's multiple individuals on there that make it right there on TV. They take out one step or else the feds will knock on their door. One guy actually does it while wearing a red devil suit all day. It's entertaining because it's TV. So anybody know of, to my knowledge, there's no phase 3 studies for stimulant use disorder for a pharmacological agent. Am I right there or am I out of my mind? Because what Dr. Husted showed, there's a phenomenal phase 2.
That's right.
Where studies go.
Most of them are pilot studies. Most of the trials are kind of pilot trials, not really pharmaceutical company sponsored big trial, because there's nothing there.
I just bring that up because it's in talking about these TV shows or what people are doing in the streets and all that kind of stuff. We are eons away from even considering having a stimulant use disorder medication, if ever. When you think about it, there's nothing even phase 3 since we got that confirmed now. I thought that was the case, but it's a very sobering thought when you think about it compared to the options that we have in other realms. So.
I tell you the truth, the one main thing for anybody coming off meth is sleep. You give them 3 days of rest, they feel like they've become alive again, and they can go right back into the world. Mm-hmm. And it is sleep, because sleep deprivation is a big part of methamphetamine use.
Can you guys hear me? I had to shut my video down. I apologize. It was giving me some issues. Okay, make sure I gave me a thumbs up, like it. Thank you guys so much for this wonderful discussion afterwards. And it is a very heavy discussion at that. So I appreciate everybody. We're gonna run a poll. We're gonna try and do this monthly. Just please be honest. If you wanna take it, it's completely voluntary. And if you have any suggestions or, criticisms or good stuff to say, send it our way of how we can improve this for you in any matter, okay? And our next session will be August 23rd with Katie Chesson-Downs doing something on ethical discussions. Thank you so much.